So, welcome to everyone, dear colleagues, honorable participants, at today's initial One World YoungStatS webinar. It is a pleasure to open a series of online seminars, webinars we have been preparing for quite some time inside the YoungStatS project. The project itself, YoungStatS, started in October with great support of both Young Statisticians Europe, YSE, the Federation of European Statistical National Societies, FENStatS, as well as Bernoulli Society for Mathematical Statistics and Probability. We thank all of them, all of you, for their strong support so far and throughout, and thank also to those who are able to join our event today. YoungStatS project consists of two larger parts: international block, presenting short and comprehensible summaries from the most recent literature in statistics, probability, and econometrics. We have been honored that among our contributions so far have been professors Peter J. Diggle, Jonas Peters, Richard Samworth, P. Richard Hand, Julia Gill, Karel Hron, and Peter Filzmoser, among others. And a second part, webinars, that you're attending today, addressed towards presenting recent interesting work of leading young researchers in statistics, probability, and econometrics, and taking place on a monthly level from now on. Today's topic of the webinar is recent advances in the modeling of COVID-19. It will be presented in more detail throughout the webinar itself. I have to additionally note, though, that the selection for today's event wasn't easy, as the time of the present pandemic, COVID-19 pandemic, has also been time of increased interest, large interest in statistics and modeling. Many interesting models have been developed in last year. I especially mention many research groups and independent initiatives frequently taking place as COVID tracker groups, I think, throughout the world. In Slovenia, my home country, bulk of the interesting modeling work has been taking place in a similar larger group, COVID-19 Sledilnik, and I hope, I do not see now the participants current, but I think we also greet Lukarenko, coordinator of this initiative, as participant today in the audience. Additionally, I would like to mention a few topics we have been considering for the future webinars, ranging from some of the most debated current research topics from Bayesian methodologies, functional data analysis, high-dimensional data analysis, networks, network analysis, causal inference, latent variable modeling, and algebraic statistics. Those are just few ideas, definitely not exclusive. We will try to provide details about the next webinars with hopefully again an excellent speaker representation as well very soon. With this, I would leave you to today's webinar. We hope we will update you soon with more great news over the progress of our work. I do think, possibly my personal opinion, that the project YoungStatS so far justified our existence and promises to be an important part for the future of statistics and its revitalization, if needed naturally in the post-COVID period. Hoping that you will continue to follow our work in future as well. I would leave now the word to colleagues from the editorial, the moderators for today's webinar, Dr. Cristian Capezza of University of Naples, Federico II, Italy, and Dr. Geneviève Robin of CNRS, Université de Val-de-Saône, France. I hope I pronounced this well, and looking forward to an interesting webinar. I leave the word now to you, Geneviève and Cristian.
Thank you, Andrej, and I'm joining you in welcoming everyone for this webinar. We are very happy to have our first session today, and it's my pleasure to introduce our first speaker, Cécile Tran, who is a PhD student at Institut Pasteur, France. Since the beginning of the pandemic, Cécile has worked on several aspects of modeling the epidemic, for instance, measuring the impacts of different measures such as the curfew and the testing procedures. And today, so her work has had a major impact on the political decisions that have been taken in France. And today she will talk about the evaluation of the SARS-CoV-2 vaccination strategies in France using a population model. So The floor is yours, Cécile.
Thank you. Go and share my screen. This works. Yep. So thank you very much for the invitation. I'm delighted to share some of the work we've been recently doing on the evaluation of SARS-CoV-2 vaccination strategy in France. So as most of you are aware of, there has been a number of vaccine candidates that have been developed, some of which have already been authorized by a European Public Health and Medicines Agency. But so far for France and for most European countries, the number of doses will remain scarce during the first months of 2021. So we work together with the Autorité de Santé, which is the French agency in charge of the evaluation of health products to assess the impact of vaccination strategies targeted towards different age and comorbidity groups in the perspective of reducing the morbid mortality related to COVID-19. So morbid mortality, I'll focus on deaths and hospitalizations. So there remains substantial uncertainty regarding the different vaccine characteristics. And so we explored a range of scenarios to see what the potential impact these different characteristics could have. And I'll come back to that in a moment. So for this analysis, we extended a model that we developed during the first wave of SARS-CoV-2 in France to support healthcare planning by projecting hospital and ICU beds capacity requirements. So briefly, the model accounts for age-specific mixing patterns. So it uses contact matrices that are reconstructed from a contact survey, where basically you ask individuals of a given age how many contacts they had during a day, what was the age of their contacts, maybe in which setting they had the contact, etc. And then it is possible to reconstruct a contact matrix that describe the mixing patterns in the French population. So we also consider the reduced susceptibility in children for this analysis, as this has been suggested in in several analyses. The model also accounts for age-specific probability of severe outcome. So as you are probably aware of, age is a major determinant of the risk of developing a severe form of the disease, so hospital admission, ICU admission, or death. And so we reconstructed we estimated age-specific probability of severe outcomes using hospital data stratified by age, serological data, and accounting for the sensitivity of the serological tests. So the model has been already described I won't go into the detail of the model too much, but it's a compartmental model. So it's described by a set of ordinary differential equations that both describe the dynamics of spread of SARS-CoV-2 in the French population, the fact that upon contact with an infected case, susceptible individuals can get infected. And it also described it takes into account the fact that a subset of infected individuals will eventually develop a severe form of the disease and be hospitalized either in general wards or in ICU. So the model is not appropriate to evaluate the impact of vaccination strategies targeted towards elderly homes or the people who work there, and the same thing accounts for healthcare workers, because it describes the spread of SARS-CoV-2 in the general population, and the transmission dynamics in those settings is likely different. And for 2021, we assume that there would be a series of epidemic waves with the same magnitude as the one that was experienced in France during autumn 2020. So we recalibrated the model using latest hospital data. So we calibrated the model using a Bayesian Markov chain Monte Carlo framework that we calibrated on hospital and ICU admissions between March 2020 and January 2021. And so as you can see here, the model is able to reproduce quite well the dynamics of ICU and hospital admissions in metropolitan France. And for this, we used a negative binomial likelihood as described here. So a certain number of pathologies, such as, for instance, obesity or chronic kidney disease, have been associated with an increased risk of developing a severe form of COVID-19. And it's particularly interesting that some studies have found that having several conditions puts you at higher risk of developing a severe form of COVID-19. So we extended the model that was already stratified by age to include a stratification by number of comorbidities. So we used, by using relative risk of hospitalization given infection, ICU admission given hospitalization, and death given hospitalization, that have been estimated by other persons in a US-based surveillance network. So for instance, what you see here is that, from this data is that if you have, so let's say that the reference is individuals that are younger than 45 and that have no comorbidities, having 2 or more comorbidities, increasing your risk of being hospitalized if you are infected by about 5. And so by using these estimates of the relative risk for the different, so either hospitalization, ICU admission, or death, as well as the prevalence of the number of comorbidities that has been estimated by Santé Publique France, which is the French public health agency, we are able to reconstruct the probability of hospitalization, ICU admission, and death, stratified both by age and number of comorbidities. And so what you can see here, for instance, for the probability of death given hospitalization, that if you are, for individuals who are aged between 75 and 79 years old, if they have 2 or less comorbidities, their average probability of death, of in-hospital death, is about 20%, and it increases to about 35% for individuals who have at least 3 or more comorbidities. So then, as I mentioned before, there remains some uncertainty regarding the vaccine characteristics. And so vaccines can have an impact on the disease transmission and the dynamics of spreads at 3 different levels. So if we come back to a quite simplified picture of the transmission of a disease, susceptible individual will get infected upon contact with an infected case, and a fraction of them will eventually be hospitalized, and then there is a recovered state, or in hospital sometimes a portion of them will also die. So vaccine, they can first reduce the severity of SARS-CoV-2 infection. So it means that individuals who are vaccinated and who get infected, they will have a lower probability to develop a severe form of the disease. Then vaccine can have an impact on the reduction of the infectivity of vaccinated individuals. So it means that vaccinated individual, once they are infected, upon contact with the susceptible individual, they will have a lower probability to transmit the disease to those susceptible individuals. And finally, it can also reduce the susceptibility to the infection. So it means that vaccinated individuals, upon contact, that are susceptible, upon contact with an infected case, they will have a lower probability to be infected with SARS-CoV-2. And so as there remains substantial uncertainty, especially regarding the role of vaccine on transmission, we explored 3 scenarios regarding the impact of vaccine. So we explored the first vaccine that would only have an impact on the severity of the infection, reducing the probability to develop a severe form of the disease by 90%. Then we consider a vaccine that would also have an impact on transmission and that would reduce transmission by 30%. And finally, we considered a vaccine that would reduce the susceptibility of vaccinated individuals by 90%. So we first looked at strategies that would be targeted toward different age groups. So in these plots, each column corresponds to a different kind of vaccine. The first row corresponds to the percentage of deaths averted with the vaccination campaign, and the second row, the percentage of hospitalizations averted. So each line corresponds to a different age group, and the triangle corresponds to the reduction that would be obtained when 70% of vaccine coverage is reached in a given group. So for vaccines that only have an impact on the severity, we find that the most efficient strategy to reduce both death and hospitalization is the vaccination of the older individuals who are at higher risk of severe outcomes. So for instance, the vaccination of individuals age 70% of individuals that are aged over 75 would be susceptible to reduce the death by 35%, and you get much lower proportion reductions in the other age groups. When we consider this time a vaccine that has also a moderate impact on transmission, so the most efficient strategy is when you have a limited doses to reduce deaths and hospitalization is to vaccinate individuals that are at higher risk, so the older individuals. But compared to the previous graph, you see that the impact of the vaccination of the younger age group is more important. And so this is because these age groups play an important role in the transmission of the disease. And so vaccinating them, even if they are at lower risk of developing a severe form of the disease, will mean that they will in turn transmit less to other people, and so therefore reduce the total burden of the disease in the population. And finally, when we consider the vaccine that reduces this time the susceptibility to the infection, we find that to reduce the deaths, we get rather similar levels of reduction when vaccinating both younger age groups and older age groups, and higher levels of reductions can be obtained when vaccinating a younger individual, and this can be explained by the same reason that this group contributes a lot to the transmission of the disease. So another metric that can be used to evaluate the impact of strategies is is to look at life years lost and quality adjusted life years, so QALYs. So compared to life years lost, QALYs are just life years lost where there is a weight depending on the quality of life that individual attributes to being a certain age and living with certain conditions. So it's the same panel, but on the first line it's the spared life years, and on the second line the spared QALYs. So for a vaccine that reduces the severity, we see that the impact is still the most important when the vaccination is targeted toward older age groups that are at higher risk of severe outcomes. When we this time look at a vaccine that also has an impact on transmission, we see the same pattern as we saw before, where we can have also an important impact on the reduction of the mortality by vaccinating younger age groups as well. And for a vaccine that reduces the susceptibility of the infection, we see that the most important reductions can be obtained when vaccinating younger age groups, though the levels of reduction we can obtain by vaccinating, for instance, individuals over 75 can also be quite substantial. So as we had a model that is stratified on age and comorbidity, we can also look at strategies that are targeted towards different age and comorbidity group. So this is what we did in this slide. So the first line is still the percentage of deaths averted. Second line is still the percentage of hospitalization that are averted, still our three vaccine types. And the dotted line indicates the vaccination of individuals who have 2 or more comorbidities, the dashed line, the one with individuals who have 1 comorbidity, and the plain line, individuals who have no comorbidity. So what we can see for a vaccine that reduces the severity and that also has an impact on both for the first 2 vaccines, that the strategy that has a larger impact on the reduction of death and hospitalization is always the vaccination of individuals aged above 75 years old, even when accounting for the comorbidities within the age group, within younger age groups. So for instance, if we have about 2 million doses, that would enable to vaccinate 1 million people, because we consider 2 doses scheme. we can get a reduction of about 7.5% by allocating them to the older age groups, and the reductions are lower, about 4% when targeted toward individuals who are 65 to 74 years old with 2 or more comorbidities. And then when we looked at the vaccines that have an impact on the susceptibility, we see kind of similar patterns to what we saw before, so that we can have to reduce the deaths. We have rather similar levels of reductions when vaccinating younger age groups and older age groups. And for the hospitalization, we can have slightly larger reductions when vaccinating younger age groups than the 75 years old, the individuals above 75 years old. So we then looked at vaccine prioritization strategies where we would not consider groups independently, but consider the whole distribution of vaccines. So we first looked at a strategy where vaccines are distributed at random. So it means that vaccines are distributed at random in the population above 18 years old. And so someone aged 20 or 80 would have the same probability to be vaccinated at a given time. We then looked at a prioritization that would be based on age, with decreasing age. So we would start with individuals that are older than 75 years old. When we reach 75% of vaccine coverage in this group, we start to vaccinate the younger age groups, so the 65-74. When we reach 70% of vaccine coverage in this group, we switch to another age group, another age group that are the 50-64, etc., until reaching the younger age groups. And we then considered strategies that would be prioritized based on decreasing age and comorbidities. So we would always start by decreasing age, but within the age, we would also add a stratification by comorbidity. So we would first allocate the doses to 70% of the individuals over 75 years old, and then we would switch to individuals that are 65 to 74 years old with at least 2 comorbidities. Then when we reach 70% of vaccine coverage in this group, we switch to vaccinating 65-74 with 1 comorbidity, etc. And then we go in decreasing order until reaching the 1849 years old without any comorbidity. And so here are the same panels. So when we consider a vaccine that reduces the severity of the infection, what is pretty blatant is that so the prioritized strategies allow to avert way more deaths and hospitalization than the strategy targeted at random. So for instance, if we have 20 million dose, the strategy at random would allow to reduce deaths by about 10%, but the prioritized strategy would allow to reduce death by more than 40%. So we see this rather similar pattern for vaccine that reduces the severity and vaccine that reduces the severity and that have a moderate impact on transmission, although the differential is lower for a vaccine that has an impact on transmission. And then for a vaccine that reduces the susceptibility to the infection, see that we have rather similar results across both three strategies when minimizing the number of, trying to minimize the number of deaths. And when we're trying to minimize the number of hospitalization, the strategy are rather similar in the first, for the first doses, and then the strategy at random is a bit more efficient, which can be explained in the same way as, so it's the fact that the younger individuals contribute a lot to the disease spread, and so reducing their susceptibility can have a substantial impact on the dynamics of the disease. So what we can see here is that the strategy based on age and comorbidity is always results in a bit more reduction than for the strategy based on age. These plots don't really allow to compare these two strategies because there is always a point where you catch, so individuals, at some point the strategy match in some sort. So it's not the best way to assess the differences. The differences could still be substantial if at some point you start to vaccinate individuals who are at higher risk within an age group, especially if it's at a time of the epidemic dynamics where there is a high transmission intensity. And so my conclusion slide is gone, but that's okay. So yeah, I presented some of the results where we focused on the early stage of the vaccination campaign where there are scarce doses. Now we are also currently extending this analysis to account for the fact that there are vaccines that are being made available in France and that have most likely different levels of efficacy. So the question is asked, what's the impact of allocating these vaccines to one group or another? And then there is also the question of which level of vaccine coverage in the different age groups, both at risk and non-at-risk group, would allow to come back to a situation in our everyday life as normal as possible, and so to release some of the control measures that are currently being implemented, and especially in the context of the emergence of the variant of concern, VOC, in France and in Europe. So I'd like to thank all the contributors and collaborators for this analysis, people at Pasteur, École des hautes études en santé publique, INSERM, Santé publique France, and the Haute Autorité de Santé. Thank you.
Thank you very much, Cécile, for a very clear and interesting talk. So if you have questions, you can write them in the chat. Is there any questions so far? We have maybe 2 minutes for 1 or 2 questions. Maybe I can start with, so I have 2 questions actually. The first one is, I was wondering, so you consider different vaccination scenarios and I mean vaccine efficacy scenarios. And I was wondering where they come from. Like, how did you decide to use these 3 specific scenarios?
So we discussed the scenario together with the Haute Autorité de Santé and Santé publique France, who helped us define the scenarios. So the 19% efficacy comes from some of the clinical trials, especially for the mRNA vaccine, so Pfizer and Moderna, report an efficacy higher than 90%. So that's why this kind of justified the 90%. To estimate impact that a vaccine could have on transmission, the data are not really out yet. It's a bit complicated, and most likely you need to do some contact tracing or to do some household studies to know the people who got vaccinated, have there been more or less cases around them. So the data are not out yet. And for the vaccine that reduces the susceptibility, so the 90% is still the same. So the justification between splitting the different scenario is that as the clinical trials only look at the proportion of people who develop symptoms, they might miss some asymptomatic infection. And so when they report an efficacy of 90%, it's not obvious whether it comes from the fact that people just have a lower probability to develop a symptomatic form of the disease, or whether they were not infected. And the dynamics in terms of like which vaccine to allocate to whom is very different. So this is why we explored these different scenarios.
Okay, thank you. There is one question in the chat from Kevin Kunzmann, who's asking if you looked into combined vaccination and mobility reduction strategies.
So the scenario we didn't, so this analysis is not really looking at the combination of both. I guess it's, so in ours, we took an epidemiological scenario that would be a series of waves that would be characterized by an increase in transmission intensity, then reductions, maybe thanks to the implementation of control measures or other external factor, climate, personal behaviors, etc. The epidemiological scenario we would consider is a scenario where there are some control measures, and so where mobility is rather reduced, where there are some physical distancing of the people. because at least in the early stage of vaccination, and while we don't know whether vaccine reduces transmission, a vaccination alone is not sufficient to control the spread of the epidemic and avoid the overwhelming of the healthcare system. I guess the question of the reduction of mobility, for like in France and in other countries, I can relate it to the question of when we will be able to reduce to limit the control measures and to be able to come back to normal life. And so you could see that as, so when could control measure, there will be enough vaccine coverage in the population to be able to release some of the control measures. And so this will come when a substantial proportion of the population will be vaccinated.
Thank you very much for your answers. So, and for your great talk again. Now we will move on to the second speaker, who are two speakers jointly, and I will let Christian and Capezza introduce.
Yeah, thanks, Geneviève. So next we have two Italian speakers. We are Pierfrancesco and Marco, Pierfrancesco Alaimo di Loro and Marco Mingione, who are PhD students in statistics at the University of Rome, La Sapienza. And they are also collaborators of one famous Italian group who works on COVID-19, who's Stat Group 19, which is a scientific research group who works on COVID-19, of course. And the title of their talk is Nowcasting Italian COVID-19 Epidemic. Okay, so I just want to add that they are going to dedicate probably a section of the talk to a web application they developed through Shiny. So I let you to start your presentation. Thanks.
Okay.
Thank you.
Sure. Okay, so it's this one. Okay, here we are. So can you see my screen?
Yes.
Yes? Okay, good. So good afternoon, everybody. And from me, Pierfrancesco Alaimo di Loro, and my colleague Marco Mingione. First of all, I wanted to thank Professor Srakar and everybody in the organization for inviting us at this webinar. And also Stat Group 19 for involving us in this very stimulating research opportunity on COVID-19. So during the presentation, we will briefly introduce some of the strategies to model the COVID-19 evolution during his first phase, its first spread. We're talking about the month of March, April, and May of last year. And we will introduce our research-driven GLM model. And after that, Marco will also talk to you about a Shiny app that we devised and made publicly available on an IO Shiny server, and that is currently online and daily updated by us. So first of all, usually in order to model the spread of an epidemic, the coronavirus as well, the most common used models are compartmental models, of which the SIR is a specific example, probably the most common and most famous one, which is actually probably the correct way to model an epidemic spread. Indeed, it is an epidemiological model that is allowed to model the epidemic all round in all its aspects all together at the same time. And evidently, it also correctly describes the underlying dynamic of the spread of an epidemic, having susceptible subjects, infected subjects, and recovered subjects. Nevertheless, the compartmental models are based on so-called chaotic systems. Chaotic systems are highly dependent on the initial conditions and on the hypothesis that we impose about the evolution of the process. And therefore, even the slightest bias or misspecification can lead to completely different results. Especially in the initial phases of the epidemic, when few information were known about the coronavirus, its spread dynamic, and also the quality of the data. I mean, it's not that good even now, but especially the public data were not so of high quality, and also they were not very detailed. Many research groups that tried to use this model to provide forecasts provided forecasts very different from each other's. And most of them also proved to be completely wrong. We remember about saying the pandemic would be ended by the end of April, or some others saying that the pandemic would explode by June, and this never happened actually. So some other research groups decided to resort to something a bit different, probably less accurate from a data generative process point of view, but which is the direct data modeling. So go and model the indicators as a time series or as data as they are, somehow neglecting their nature as counts of as indicators of a pandemic which is spreading. So we are using somehow statistical artifacts that don't rely on very strong hypotheses, but just try to draw as more information as possible from the statistical properties of the data we are observing. Obviously, also when dealing with this kind of modeling, we have to be aware of a number of pitfalls, because these kind of indicators have some characteristics that we cannot neglect. Obviously, there is some kind of serial dependence between the indicator observed in different days, and most of these indicators usually are counts. And in the literature, we have seen a lot of models assuming Gaussianity on the log counts, which actually is not correct from a probabilistic point of view. I mean, counts are discrete numbers, log counts are discrete as well, and therefore the assumption on Gaussianity cannot hold at all. And especially, we know that on counts, there is a very strong dependence between the mean of the random variable and the variance of the random variable, while under Gaussianity assumptions, mean and variance are independent parameters. We have also seen about modeling the mean of these indicators using a basic decomposition, which is fine. This basic decomposition, like splines or polynomials, are very flexible and can provide very good fits on the observed data. Nevertheless, they are not very accurate. Actually, they can be completely wrong when we try to extrapolate outside of the fitting region of the observation region, because we cannot control the behavior of this decomposition outside of the fitting region. So they can be good to provide a good fit, maybe also forecast a very short time horizon, like 1 or 2 days, but forecasts on large time horizons usually diverge. And these kind of indicators cannot diverge at all. They obviously can get to 0 at minimum, or at most, we have all the population infected. So we wanted to do something in this area, in direct data modeling, during the first period of the epidemic, in order to have some easy, accessible tool that could work on the public data and provide accurate predictions on a medium term, and to understand in which phases of the epidemic we were finding ourselves. We decided to use only the data publicly made available by the Italian Protezione Civile on their GitHub repository, which can be classified in 2 main classes, which are prevalence indicators and incidence indicators. In particular, we focus on the incidence indicators, which are usually reported as cumulative number of positives, cumulative number of deceased, cumulative number of discharged or recovered, and actually represent flows. There are flows. Why? Because actually the cumulative indicator at each time t is nothing else but the sum of the daily indicators, so the flows that happen, that evolve over all day. So we get here that the cumulative indicator at time t is nothing else but a baseline plus the daily indicators at each previous day. In the same way, we can get back the daily indicators, the daily incidence indicator, as the difference between the cumulative indicator at time t and the cumulative indicator at time t-1. By a first visual inspection of the cumulative indicators, us, but many other research groups, realized that probably the behavior of these cumulative indicators on average could be well represented by a logistic growth curve. So us, for instance, considered modeling this average along time as a Richards curve, which is probably the most, or one of the most flexible ways of defining a logistic growth curve model. It's also known as the generalized logistic curve, and depends on these 5 parameters. I won't go into details on that. But after doing that, we asked ourselves, shall we model the cumulative counts directly, assuming this mean behavior and deriving the parameters? Before doing that, we realized that there was one thing we couldn't forget about. The thing is that the series of cumulative counts cannot vary freely. I mean, the cumulative count at time t is bounded to be always larger than the cumulative count at time t-1. Modeling the mean using a growth curve implies that the mean at time t is larger than the mean at time t-1. But this does not imply at all that the count will be in fact larger than the count at time t-1. we wanted to find a way to impose also that the count at time t was in fact larger than the count at time t-1. So we decided to take a switch of perspective, and instead of modeling the cumulative counts, we asked ourselves, why don't we model the daily counts and then derive a model for the cumulative counts from the model of the daily counts? The good thing about the daily counts is that the daily counts are all between 0 and plus infinity. They are not constrained to be larger than anything else, so they can easily be modeled by any count distribution like a Poisson or a negative binomial. But at the same time, we wanted to keep this constraint, this assumption that the cumulative counts were growing according to a Richards curve. How do we do that? Well, it's pretty straightforward, actually, what we did. So knowing that the mean of the cumulative counts should behave as a Richards curve, then the mean of the daily count shall behave as the first differences of a Richards curve. So we decided to parameterize the mean term of the Poisson or of the negative binomial using the first differences of a Richards in here. In particular, this model allows to include the effect of any additional covariates that you want. I don't know, maybe a weekend effect, or maybe the effect of the number of swabs taken every day on the mean in an additive or multiplicative fashion. I mean, adding a term A plus or multiplying a term A times, obviously doing so in a way that we can respect the positivity constraint on the mean. Anyway, I won't go into much details with that. I just want to show you here that in practice, we are assuming that the daily counts have the behavior of the first differences over Richards, so that the cumulative count on average will respect the behavior of a Richards curve, like this one on the left. An additional assumption that we did, actually this is the strongest assumption that we take, and but it's useful, it's a working assumption to derive the likelihood easily, is that the daily counts are stochastically independent from the cumulative count at the previous time, and daily counts are all stochastically independent of each other, given the mean curve is known. So in practice, this the shape of the first differences of the Richards is taking with itself all the dependence in the observations. And in this way, we can just express the cumulative counts likelihood as the product of the marginal likelihood of the daily counts, which are all independent of each other. In order to get estimates for the gamma parameters, which are the parameters on which the first differences Richards depend on, we decided to use, first of all, a pragmatist approach, so log likelihood maximization based on a multi-start routine optimization based on efficient scoring, where the gradient and deviation of both the Poisson and negative binomial have been computed analytically so that we could hasten and robustify the optimization procedure. In addition, we decided to quantify the uncertainty of our estimates using the inverse of deviation in the point of maximum, and then deriving prediction intervals by bootstrapping simulations from the asymptotic distribution of the MLE, and then producing fake observations from the distribution given the simulated values. What we got at the end for modeling the first wave of the pandemic are the following results, where we can see how on the daily indicators, we get a pretty good fit on the observed data, and also all the counts seem to be included. Actually, it's the 98% of them is included inside the confidence bound at the 95% level. This on the right is what we get for the cumulative counts starting from the daily counts on the left. And actually, it's not surprising that we get here bounds getting larger and larger, because our model is on the daily counts, and here the intervals are point-wise intervals, while on the right we don't have point-wise intervals, but we have a curve-wise interval. Somehow, in each point, this interval is taking into account the uncertainty of all the previous points. So these are all the possible different trajectories we could have observed. You have to understand that for the cumulative counts, even one of these points a bit up would imply that the whole curve after would be a bit up. So this is an interval for the whole curve after that point, not just for this point and by itself. We also wanted to verify the ability of our model to forecast and to make predictions on new data. So we tested the 1 step, 5 steps, 10 steps, and 15 steps ahead predictions, considering different fitting intervals. As we can see, as the fitting interval increases, the prediction accuracy increases. But the good thing is that 1 step ahead, 5 steps ahead, 10 steps ahead, the 50 steps ahead predictions actually have approximately the same accuracy. This means that our model is as accurate on the short term as on the medium term, and seems to be representing getting the view of the epidemic kind of globally, at least along one single wave. The second thing we wanted to test is to verify if we could have been able to predict the peak in the daily disease, for instance, in advance. And here we detected the true peak by fitting our model to the whole set of data. And then we try to fit the model only on a subsection of the data, the one 10 days before the true peak, 5 days before the true peak, 2 days and 1 day, and see if the predicted peak would coincide or not with the true peak. And apparently our model was able to predict the true peak even since 10 days before the true peak was observed, with 2 or 3 days at most error accuracy. In general, the good thing is that the true peaks is always included into the interval of the interval of the estimated peak. So I already got a bit late, I think, because I need to leave some space for Marco. So now Marco will talk to you about the Shiny app that we devised, and will drive you through all his specifics. Marco,
yes.
over to you.
Yep, thank you. Thanks to Pierfrancesco, and I join him in thanking also Stat Group and Dr. Srakar and all the organizers for giving us the opportunity to join this webinar today. And I'm going to briefly introduce our Shiny app. And as many of you will know, Shiny is a shortcut, I would say, to build web-based application without necessarily being familiar with HTML programming. And I thank sadly Wicam for this. Our app was built to provide the general public with an interactive tool to access the epidemics data in a transparent way, and is automatically updated every time a user logs in. It is mainly composed of 4 tabs plus an info and credit section. And in there you can find a link to Stat Group 19 social media, in which you can find very useful discussion about the accessibility to high quality data, and also about how the epidemic is going. And then you also have a link to the GitHub repository of Italian Civil Protection, which is our main data source, and to our GitHub repository, in which we put the codes to reproduce the app. So Pierfrancesco is gonna load the app, I think, and I'm gonna describe it to you. Okay, on the run. Yes, the first tab is the overview, and it's actually a picture of the Italian epidemic at the most recent update. It is divided into 4 subsections. The first one is the daily report of the Italian Civil Protection. And if you have any doubts about the definition of the indicator, or how to navigate and use the web application, you can click on the help button, or you can download the user guide, which is in English. And then you have the timeline of the decrease. And this is very important if you wanna properly interpret the measures put in place by the government in order to contain the spread of the contagion. You have the link to the official documents, and each decree is colored by its category. Then we put 3 different subsections, mostly including time series and maps, because we wanted to investigate more deeply the temporal and the spatial evolution of the epidemic indicators. You also have time series of ratios, healing rate, fatality rates, a lot of stuff. And you can customize several choices. You can see the time series by region. You can look at the daily variations, weekly variations. and rescale the map with respect to the population size. And particularly for the cumulative positives, you also have the province level detail. And at last, we put the table, which is downloadable with the raw data. We color-coded a couple of columns, and darker values correspond to those values that are larger with respect to values of the previous days. And we put some relative indices for allowing a proper comparison among regions. The second section of the app is, I won't go into details because Pierfrancesco already said almost everything about it, and it allows for the modeling on the run of the incidence indicators. You can zoom the plot, you can interactively see the forecast up to the next 15 days. And we also report the estimated peak, which is, in this example, I think these new positives in Italy was estimated around the 13th of March, and also a couple of goodness of fit measures. Well, okay, then we dedicated a specific section to the ICU occupancy. And in our opinion, this indicator was the most accurately monitored during the epidemic. And this is not a surprise, since the overcrowding of hospital facilities is probably the most difficult challenge that the national healthcare system had to face and still have to face. And here, with an ensemble method, which is currently published on Biometrical Journal, we provide point prediction for ICU occupancy by region at 1 day ahead, together with 99% confidence intervals. And below, the user can download and compare past predictions with the actually observed values. Back to the 17th of March. And the last section we add to the Shiny app is about the vaccination campaign. You can see how it is going in Italy, and you can compare region performances with respect to the administration rate, and also see the vaccination, the vaccine distribution in the population by gender, category, or age class. Well, yes, this is the info and credits. All the links are here. We want to thank our colleagues from the Stat Group 19, and we can go back to the slides and conclude. So yes, to sum up, we want to say that we proposed a robust distributional framework which is coherent with the nature of the data, and the model is flexible enough to adapt to any incidence indicator at both national and regional level. And even if we didn't go into detail, you can easily add covariates on the mean. And of course, as you just seen, we built this Shiny app. It is not the only one on COVID-19, but we wanted to give our own contribution. And currently we are developing Bayesian counterparts to our model, possibly including temporal and spatial dependence, and also try to develop an extension of our model mirroring the research for prevalence indicators. And this is a list with the main references. And we thank you for your attention. And if you have any question, we are willing to answer.
Okay, thanks to Pierfrancesco and Marco for your interesting presentation. Okay, I see just a couple of questions that have been asked right now. One from Immacurato, which is, okay, thank you guys for the nice talk. Yup, is fantastic. Yes. And which type of dependence you would like to include in your model?
So I go on this one, Marco?
Yes, yes.
Okay. So the idea is that these assumptions we do here are pretty strong. I mean, we can imagine that somehow at least the daily innovation, this is like, our model is like we have a baseline and some daily innovation. It's like we have a normal plus an error, which is not a Gaussian error, which is not a Gaussian error, but is a Poisson innovation somehow, if we read it in time series version. And I think that the strong assumption here is that we are assuming that the daily innovations are independent from each other. Instead, we think that somehow there has to be some dependence. I mean, if I see a very large count today, maybe larger than I expected 1 day ago, maybe I may expect also the next one to be very large, or maybe even a negative dependence, somehow something like if I, since these indicators are collected, I mean, when we have the daily positives, they are not actually the people that got infected today. They are the people that are reported infected by the Italian Protezione Civile. We can expect that there is some mechanism going on there, for which, like, if I report a lot of people today, probably I will report less people tomorrow. So maybe there is some kind of negative dependence, and this is what we are observing right now when we are doing this analysis. But I think in general, what we want to change is these independence assumptions here. So trying to put some dependency between daily counts of following days, or maybe even going 1 week 1 week back and say that the daily count of today, which is Monday, will be somehow correlated to the daily count of last Monday. This is what we're trying to do.
Okay, perfect. And there's another question from Andrej Srakar. Is the model able to model the possible breaks in time series and possibly the changes between the waves? And I know, though, it is a no-casting model.
Well, yeah. Oh, you want to answer,
Okay.
Pierfrancesco?
As you want. I can go on this one, or you can.
I can probably ask half. Answer half of the question. Yeah. Yeah. We tried. I mean, we want to in the next future to develop a sort of mixture of Richard's curves in order to to model the epidemic as a whole, not to necessarily distinguish between the first part and the second part, so between waves. And we try to include as a covariate also the number of swabs to follow to better follow the trend of the positives. But it's not I would say correct statistical choice, since they are highly correlated and you cannot know the number of swabs in advance. So I don't know if I answered properly, and Francesco wants to add something.
Yeah, just about the swabs. I mean, if we include the swabs done as a covariate, the fit of the model improves a lot. What is that? It's not completely correct, because it's not like we decide to do more swabs independently of the state of the pandemic. People infected people that are supposedly infected ask for more swabs. So if we include the swabs information, we are including somehow the number of new positives information. I don't know if I explain myself correctly. I mean, there is correlation between the number of swabs and the number of positives. It's not like the number of swabs done is independent of the number of positives in the population.
Thanks. It has been explained. Thanks.
Okay, perfect.
You're welcome.
I see another couple of questions. I would leave space at least for another one. Then maybe, I don't know if it's better to go forward and leave other questions in the discussion. I would say just another one from Juan Jose Egotsku. I'm sorry for bad pronunciation. Have you considered?
Christian, apologies. I would suggest just to move forward to be in line with the
Okay,
time.
that's perfect.
Questions.
Okay. So let's move forward, and
Thanks.
Let's leave these questions for the discussions later. Well, so we move on. So we have the next speaker, which is Kunzmann from the University of Cambridge. He works in the, He works in the Medical Research Council Biostatistics Unit of the University of Cambridge, and he's going to give his presentation on simulating COVID-19 policies for school reopening during COVID-19. So thank you, Kevin, and welcome to this webinar.
Yeah, thanks for the kind introduction and the opportunity to present our work here. So we're a bit on the other end of the scale in terms of the populations that we're looking at, because this is a very small scale.
Sorry, is it only me, or there's something wrong with the audio? It's only me. Okay, it's better if it's only me.
No. Also me. I had the same problem.
Hear it.
Oh, okay.
Only you.
Yeah, we don't
Okay.
hear you very well.
Please try again, Kevin, because the audio was not the best quality. Sorry.
Let's see what the problem is.
Try again, Kevin, please.
Hello.
Maybe you could try turning off the camera, or
Yeah.
Hello, is that better?
Yeah, now the audio is
yes, much better.
Yes, much better. Yep.
Yes,
Okay.
thanks too.
Try to share again the screen.
Let's try again. Okay, so I hope it works now. Yeah, so we are looking at kind of the other end of the spectrum, very small populations. As you might know, the schools currently are closed in the United Kingdom, and obviously people are discussing potential policies for reopening them safely. And so this is a relatively new project together with Professor Sylvia Richardson, also from the MRC-BSU, Professor Sheila Bird. And it's still very much a work in progress. So we're very happy for any kind of feedback that you have in terms of improving these things. And please do take everything, especially everything results related, with a grain of salt. So that's how it's supposed to look like, right? And as I said, at the moment, it's more like this. It's completely closed, and yeah, so we're looking at kind of policy making for reopening schools safely. So the agenda for the talk is just very briefly having a look at the UK situation as of February 2021, then a general kind of idea about how policy simulation could help in this situation, why we're looking at this in the first place. Then I'm going into the details of the model that we're using at the moment, particularly the population structure that we're using, the disease progression model, and how we model test characteristics. And then maybe some words on implementation. It was also a bit of a journey, because we started out in kind of a combination of R and C++, didn't really work that well, and ultimately ended up with Julia. And then some preliminary results as well. So what we have at the moment is it's a bit fractured, a bit fragmented across the UK, and mainly focusing on England. So the rules in Wales, Northern Ireland, Scotland, everything might be a bit different. That's all kind of agreed on a local level. And at the moment, the schools have been closed since the 4th of January. In lieu of the third national lockdown that we're having. And so earliest opening date at the moment envisioned is the 8th of March, could probably also be delayed a bit at the moment. There's a lot of worries about these variants going around. Obviously, prolonged school closures is a severe burden, and I want to stress not only for the kids, but also for the parents who have to look after them at home. Maybe some of you are in that situation as well, I don't know. That is particularly burdensome for parents and younger kids. So in this instance, this affects primary schools more so than higher education, right? Remote learning doesn't really work, so primary schools are really the hotspot here. And so the general consensus seems to be that there is a relatively low health risk in terms of infection for younger children. But schools might still act as transmission vectors, right? So they kind of, kids might act as in-betweens between teachers and parents, different families, and so on and so forth. And but looking at this from the perspective of kids, the number of missed school days and the isolation itself is probably the more consequential kind of burden that they are suffering from than the actual health risk. And a kind of specificity of the discussion in the UK at the moment is that there is a lot of there's a lot of discussion about the use of lateral flow devices or other screening tests in order to kind of enable testing free. And there is a big debate about the test characteristics of these, so how well they actually work in terms of sensitivity and specificity, and how they could become a component of the reopening policies. So the question is, how do you proceed with reopening the schools, and in particular,
Kevin,
yes?
I apologize. I have been appointed. Possibly it would be good that you turn off the video. The sound or anything might be better. Now it is a little bit, maybe just, we could try.
Turn off the video?
Yes, possibly.
Okay, do that.
Great.
I'm
Let's try.
really sorry.
The sound is a little bit weak.
Okay.
Thanks.
So policy simulation, if you go down the road of analytical, trying to model these finite populations with an analytical model, it very quickly gets analytically intractable and it becomes relatively inflexible. And particularly in the situation that we are in now, we also want to be very open to input from other decision makers, and so we need to stay flexible. And then having an agent-based simulation model, you essentially end up with a sandbox where you can play around and you can trial and error a lot without regretting anything. Very flexible, and also it's very easy to verify, right? So the kind of looking at the code and the implementation is relatively straightforward. And ideally, you would want to optimize policy as well, kind of picking the best strategy to go forward. But then you would have to define your policy space in a very quantitative manner and kind of automatically optimize over those. And given the current data situation that we have, particularly young children, I think it's realistically the best thing that you can hope for is doing a lot of sensitivity analyses, trying to identify crucial parameters and assumptions, and then rooting out kind of the bad strategies that you might follow. And so our simple agent-based model that we're using at the moment uses so first of all, it only focuses on the pupils. So we're abstracting away all the stuff in the school environment. And then we're having a 3-level hierarchy. So you have the individual within a bubble, within a class, and that one within a school. And so the bubbles, they consist of the closest friends in the play group. And within the bubble, there is no effective isolation possible. Keep in mind that we're looking at primary schools. Then the class level is kind of the next level, intermediate level in the hierarchy, is still relatively strongly connected. And on the school level, we assume that individuals are only loosely connected. It's kind of abstracted away the effect of shared staff, way to and back from school, these kind of things. The time resolution is daily. And we're assuming that any kind of policy intervention is handled before people meet in the respective groups on a daily basis. External infections, fixed chance per pupil and day at the moment. And the time horizon that we're looking at is roughly 12 weeks. So that will be one term. So if we take a typical school in the UK, typical primary school will be 12 classes, 252 pupils on average. So that's 12 classes. 3 bubbles each is a realistic assumption. So the structure would look like this. You have a low connectivity on the school level, you have a high connectivity within the classes, and you have a very high connectivity within each of the bubbles. The scale of the connectivity here referring to the expected number of risk contacts per day. The disease model that we're using follows a suggestion by Alaimo et al. And is essentially centered around the viral load trajectories. So we are sampling viral load trajectories per individual, and then connect infectivity, infection probability, and the sensitivity of the test characteristics to the latent viral load that we sampled. Crucial assumption is the fraction of symptomatic versus non-symptomatic individuals. At the moment, we're assuming around 50-50. Again, data in children is a bit shaky here. Then you sample a peak viral load, and onset time, so it's the first time where kind of the minimum detectability threshold in terms of copy number is crossed. A clearance time, so that's the time where the individual is no longer infectious, and the clearance time in that model is the only difference between the symptomatic and non-symptomatic cases. So the clearance time is later for symptomatic cases, which means that they're infectious for a longer time. At the moment, the probability for non-COVID related symptoms is just a fixed 1% per day. Again, that's not very well founded at the moment. And also, obviously, we are looking at school external infections. It's roughly 1 infection per week. If you then look at the random sample of the viral load trajectories that you get out of that model, it looks something like that. So you have asymptomatic cases, the entirely red curves here. So they never show any symptoms. And then you have the ultimately symptomatic cases, which is here shown with the symptomatic part of the disease course is the blue part of the curve. The black line corresponds to the infectivity threshold. It's 1 to the power of 6, 10 to the power of 6 copies of the viral RNA. And so the difference between the symptomatic and non-symptomatic cases is that the non-symptomatic cases, they decrease quicker. The infection model that we're looking at here is, again, that's following the suggested Loro model, and the infection probability is essentially proportionate to the excess viral load over a infectivity threshold. It's kind of this term here. So the infectivity threshold in the Loro model paper is the 10 to the power of 6. And then this is proportionate to the log 10 viral load in excess of that. And this crucial parameter, this infectivity threshold, this infectivity constant that you have here, that needs to be calibrated, for instance, with respect to a reproduction number or anything like that. That's kind of the crucial input that you have here. And of course, we want to look at the screening test characteristics as well. So we need to model that as well. Data on the available screening tests is really scarce at the moment. There was a Liverpool study that showed that depending on who did the test and at what time the test was taken in respect to the copy cycle of the viral load, you get a sensitivity from essentially 10% up to 90%, so it varies. And of course, if your policy includes screening tests, then the sensitivity characteristics will massively impact the results that you get. So what we do here is we assume that there is a within pupil random effect that we just sample from a standard normal distribution, and then our sensitivity model is essentially a logistic regression with a random effect per pupil here, and the dependency on the viral load is again proportionate to the log 10 of the viral load in excess of the limit of detection. So for the sample that I showed earlier, the corresponding sensitivity curves look like this. So you have the limit of detection, and this is under the Loro model disease model. This is the maximum viral load that you would expect. So the sensitivity ranges roughly between 0 and 80%, which is very, very roughly in line with the findings of that initial Liverpool study. And the individuals vary around that kind of typical sensitivity curve depending on the random effect that we sampled for them. Another way of looking at these two components of the model is then to look at the curves of sensitivity and infection probability over time. So the probability of a positive test and the infection probability over time. And these are the trajectories that you see here. Again, the infection probability, that's kind of the crucial bit, needs to be calibrated. So the actual height of the red curve in relationship to the blue curve here, that's a crucial thing that needs to be calibrated. And the vertical gray bars here would correspond to actual positive test results under a daily testing regime. And you can see that the random effects model that we're using introduces a serial correlation between positive tests, which is exactly what you would expect. In terms of the policies that we looked at the moment, we have a selection of 4 here. So the default is that we have a symptomatic self-isolation for 10 days and the PCR follow-up, and the corresponding bubble of the kid that self-isolated only isolates from the day of a positive PCR result. And we're assuming a 2-day turnaround for the PCR result. So while during the first 2 days of an individual self-isolating, the rest of the bubble would still attend school. And only after a positive PCR result comes back, the bubble also isolates. You can then look at policies with the same policy with an extended weekend, essentially. So here we just sending everyone home on a Thursday and a Friday. And yet another strategy is regular screening. So that's the first one, taking into account screening tests. Initially, it was discussed that people should be tested every day, but that obviously puts a lot of burden on staff and also on the pupils. Having to do a nasal swab every day before school is probably not the most convenient. So this is looking at an LFD test every Monday for every pupil, which is a bit more realistic. And then again, you have symptomatic or LFD positive pupils isolating, and the entire bubble gets PCR tested in this case. And finally, another strategy that was discussed is the so-called test and release. So as soon as anyone is either symptomatic or becomes or gets an LFD positive screening test, there is self-isolation and PCR follow-up. And the corresponding bubble of whoever became symptomatic or got a positive LFD test starts a daily LFD testing program. So everyone is being followed up with screening tests, but only after in their respective bubble there has been a case that was symptomatic or already had a positive test. And here we're assuming a 7-day follow-up. Yeah, as I said, kind of these small-scale agent-based models, they kind of lend themselves towards an object-oriented programming approach. C++ would be the natural choice. Quick, of course, very efficient in terms of computing time, but it's difficult to make it easily composable if you want to play around with policies. Pure R is way too slow. So what we tried initially was using RCPP, but it turned out that when you think about parallelization in, like, over multiple CPU cores and so on and so forth, sharing the C pointers didn't really work that well. So not really the nicest framework to develop in. And then, yeah, as I said, we ended up in Julia, kind of a new programming language, and that's very easily extensible, has a syntax relatively close to R. It's really fast. It's absolutely no speed issues. You can run all the simulations on a laptop here, and you can connect it very easily to R for plotting or Shiny apps, these kind of things, with the Julia call package. So that's really a great way of working with these things relatively interactively. And yeah, so as soon as we're a bit more comfortable with kind of the underpinnings of what we have, the code will be made available on GitHub. And if you're interested in following any of that, just let me know, and I'll give you a shout once that happens. Okay, I think it's time for some initial results. Let's have a look at what these policies look like. So the color coding differentiates between the different policies, and then we looked at different scenarios in terms of the R0, so that's essentially the infectivity, and we calibrated the gamma infectivity constant to those respective R0 values. So it's the replication with the
Kevin, I'm really sorry to intervene again. Would it be possible to end in a minute or two, because there is also the discussion and so on? Just
yeah, absolutely. Yeah.
Thanks.
And so the main point here is that it's very important to look at kind of different aspects of the policy. So it's not just about the number of infected pupils cumulatively that you see here, but it's also about the mean infectiousness. So it's kind of the risk that the school poses over the entire interval to the wider community. The number of PCR tests that you require, because those will be costly, not so much the screening tests that you use, and the school days missed, right? So that's the most interesting from the perspective of the pupils. And not surprisingly, extended weekend incurs a high penalty here, is performing pretty well in terms of the number of infected pupils or the mean infectivity otherwise. So these need to be balanced for decision making. Yeah. So then, in the interest of time, I think a very brief summary and outlook what we're trying to do here. So the database is still very shaky, so we still need to see that we get better data input to calibrate these things. It's really hard to get good data on viral load in children, sensitivity of test, of screening tests, and so on and so forth. And because of that, we are thinking about implementing the required sensitivity analyses as a Shiny app, probably, to make it easier to play around with the respective assumptions that go into the model. And yeah, definitely statistics and Julia is a good combination. Okay, so that would be it from my side.
Okay, perfect. Thanks to Kevin. Unfortunately, the audio was alternating with some minutes of good quality and some minutes of worse quality, but at the end, I would say the presentation was clear. So thanks. I would say, since the next step is to go with discussion, that we could include the possible questions directly in the discussion phase. What do you think, Andrej?
Yes, sure. I also suggest this to go to Professor Dhersin.
Okay, perfect. So I just want to leave to Geneviève to introduce the professor. Okay. Go.
Thanks, Christian. So first of all, I want to thank again all the speakers for 3 very nice presentations. And to conclude this webinar, we are very happy to have Professor Jean-Stéphane Dhersin as a discussant. So Jean-Stéphane is a professor at Université Sorbonne Paris Nord in Paris. And he's the head of a COVID-19 modeling platform in France called ModGov. So he has had a lot of experience related to the topic of our webinar, and we are very happy to that he accepted to be our discussant today. So remember that you can ask questions in the chat. So Jean-Stéphane will start with the discussion and will transmit your questions to the speakers if you still have some. So Jean-Stéphane, if you are ready.
Thank you. Can you hear me?
Yes, we can hear you very well.
Okay. So first of all, I would also want to thank all the speakers. The talks were very interesting. So perhaps first of all, I have a question about the data, especially for the 2 first talks. So one question during the pandemics is how to get the data and can we trace them? So perhaps can you explain us how in your country you can get the data and if they are false or based or things like this? Perhaps Cécile first?
Yes, hi. So I'll start regarding that. So for the analysis of vaccination, or more in general when we looked at trying to project some trends, we mostly worked with hospitalization data compared to case data. So case data are an early signal of the epidemic dynamics, but on the other way around, they can be more biased because they are sensitive to testing policies. Notably testing policies, and I think the topic has been mentioned a bit earlier. So the fact that the number of tests really depends on the number of positive tests, really depends on the number of tests being performed. So in France, at the beginning of the first wave, there has been a big database that has been a big surveillance system that has been put in place that describes the trajectories of COVID-19 hospitalized patients, both in public and private hospitals. So we get information about their age, their gender, the hospital where they're hospitalized, and the duration of hospitalization as well. So like when they are in here. So I think it's a pretty standard problem of dealing with epidemics. So first, like there can be some problem in the update of the data. So for instance, during summer, I remember we did not really understand because we estimate in our model the time spent in hospital, and we were estimating that the time spent in hospital and in ICU was increasing a lot, with on average reaching 40 days. And actually, digging a bit into that, we found out that just that the database was not updated regularly, and actually people were out of hospital, but it was not reported. So we eventually only started to work with the incoming flows, so the number of people that were daily hospitalized and not the people who were in hospital. And another problem with epidemic, so there's the problem of reporting delays. So when people enter hospital, even if they will eventually get reported, for instance, in the database, or even if they're reported in the case, there will be a small delay between the time when they arrive and the time where they are reported. And so if you work by date of notification, you can, there are statistical ways to correct for that, but it's also, I guess, something that we keep in mind and that we correct for. And regarding the access to the data, we worked with the French Public Health Agency that gives us access to the data. And yeah.
But would you say that for normal researcher, it's easy to get the data? Are the data public and open?
So I think there are some data that are opened, but for instance, I think so it's not by date of, so we use data by date of event and not date of reporting. And I think, for instance, in the public data, it's by date of reporting. So there are some, there are some data that are being made public. But not the line list of patients, which also makes sense not to. So there are some data that have been made public, not all of them. Yes.
Okay, thank you. And in Italy?
Yes, I think I can answer this question. And we are currently using data that are made available by the Italian Civil Protection Department. They are aggregated data at national and regional level and daily updated. The main problem is that the gathering of this data is addressed to each regional healthcare system, and each regional healthcare system has its own different transmission system and gathering system. So comparability is a bit hard. And there is the national Italian, I think it's the equivalent of the SPF of France, which has the individual data, but they're not public. And the Italian Statistical Society just submitted an official request to the authorities in order to access this data, because as you would imagine, that data are the ones that probably can allow statisticians and the scientific community to better understand how the epidemic is going in Italy. We are just working with these aggregates, and of course they're public, and there are a lot of agencies which are struggling to gathering this data. We thank them, but at least the public Italian data are not sufficient, according to us, to properly model and forecast the epidemic.
So these data were for the epidemic itself, but some other data are really interesting. For example, mobility data. Do you have information about mobility?
Yes, there is a research group which published recently a paper taking into account mobility among regions, and it took into account traffic flows and stations and airport flows, and also sailing. And it's used they use the SIR model, I think. But we are not considering them. We have the data because they made them available on their GitHub, but we are not using them. And oh yes, I wanted to say another thing, but yes, there is the GitHub repository is. You can find the link to the GitHub Italian repository on our Shiny app, and there are all the issues that you need to know there. Yes.
Okay. Now I have a question, perhaps for Kevin. Well, two questions for Kevin. One question for the data. So you have a contact matrix, and how do you get this contact matrix for the different level, the bubble, and so on?
Yeah, so we don't really have a contact level, right? We have this simpler hierarchical structure of three groups, and then you have a certain meeting probability within each group. There's no data underlying that. That's just expert opinion, right? So that's going to be sensitivity parameters.
So, for example, in France, I know someone is working on the timetables of the pupils, so to avoid them to have contacts. Have you seen that?
It is difficult though in primary school, right? So I mean, essentially when they go in class together, maybe you can keep like two that's what we call bubbles. Maybe you can keep two bubbles relatively separate. But once they're in class, they will also meet with a certain, or there's a certain chance of having a risk contact, right? So in terms of really intervention preventing risk contact with small children, that's really difficult. So essentially, you can, like, the intervention capability that you have is essentially preventing that they enter a classroom together. So another form of policy that you could look at is kind of alternating hybrid education, where you split each class in like 2 subgroups, and then one subgroup attends school on Monday and Tuesday, and then the other subgroup on Wednesday and Thursday, and on Friday they have remote education or something like that, right? But as soon as they go in class, you can't really separate them completely. Also, you can't really do contact tracing, which is why kind of the lowest level of policy intervention will be on the bubble, as in, like, if they have their playground group or something like that, that's kind of the lowest level that you can intervene on, right?
Okay, thank you. And I also have another question for you. You need a lot of LFD tests. Do you think it's possible to have all these tests?
Well, so the screening tests are actually already available. So they were bought kind of, I think, end of 2000, or kind of fall 2020 already. So it's more like, how do we use them? How good are the tests that we already have, and how do we use them effectively, right? And I guess the important question is, or the discussion kind of was kind of focused on enabling activities based on LFD testing, which is probably not the way to go forward, because the sensitivity is not really good enough for that. And so I think we need to move away a bit from that, and rather think of those as an addition that you can add into other policies to improve them further, but that they're not really a replacement for PCR testing or other kind of contact reduction methods.
Okay, thank you. We have 2 questions in the chat for Marco and Pierfrancesco. The first one is that I read the question. Have you considered multivariate models that take into account the compositional character of corpuscle model data? Excuse me.
I go with this one, Marco. So we considered, for instance, trying to model at the same time, including some kind of dependence, the new positives, the currently hospitalized, and the recovered, so that in order to give this compartmental behavior to our series of counts. The thing is that we think there is a big problem. We couldn't get our model to converge properly on there. And we think there is also a problem with the alignment of the data, because somehow there is this delay in the communication of positives and of deaths. I mean, the positives that are communicated today are not the infected of today, like the deaths communicated today are not the people that were dead yesterday, and so on. So I think that a very important step of preprocessing, and somehow in order to realign this data is very important. And with the few information we have about the data right now, it's really hard to do something like that. I think that if the public health system decides to share with us some more data about the pandemic, way more sophisticated things can be done. Maybe we can, having the individual data, we can realign somehow these observations, understanding who was infected when, who died when, and try to do something more sophisticated and interpretable. So at the moment, we cannot do that.
Yeah, if I can add that, I think is that, as Pierfrancesco was saying, these data, the public Italian data, were not gathered for statistical analysis. At first, they were gathered for surveillance. So we often experience measurement errors, data entry errors, and delays in reporting. And at the beginning, they didn't, for example, report if a patient was moved in another region because the hospital intensive care of his region or her region was not able to allow him in. So yes, in order to, at least in Italy, in order to build more sophisticated models such as compartmental models, we would need individual data and high quality data, but we are fighting for the
what even happens once in a while is that it happens that maybe one day we get a negative count for the daily positives, because somehow the healthcare system is correcting for some additional records that he put in the previous month. So like we have -100 today. So actually we should spread this -100 as -1 along the previous days from the last correction. So it's pretty chaotic right now what's going on with the data. They are not trustworthy at all. And as long as we're dealing with this, I think that it's better to keep things as simple as possible, because complicated things need good sources. And that's the thing right now.
If I may comment on that, because it's like it's really I think it's at the heart of kind of what we can learn from this, is that, I mean, we're now kind of a year into this, right? And this whole data management and data reconciliation business, it's so important. And I think if we want to prepare kind of for the next pandemic, then that's really one of those things that needs to be addressed firsthand. Really putting a lot of resources into good data cleaning, and yeah, I guess we could get a lot of much more robust and reliable results, much quicker, especially with a more sophisticated data collection system. It's a really bit frustrating from time to time.
Okay, and do you think in the UK there are discussions between the researchers and the people who provide data to know exactly the data you need?
Yeah, sure. I mean, that happens all the time. I mean, it's not really intentional, right? No one tries to provide bad data or anything like that. It's just the scale is just enormous, right? And there are even kind of randomized studies being conducted on request, more or less. But then we also had that Excel incident very early on, right? Where I think 10,000 infections were missed for 1 or 2 days because of an overflow in an Excel table. These kind of things show you what's going wrong on the infrastructure side, or what was going wrong on the infrastructure side in the beginning, right? Kind of adding to those negative counts that you're experiencing.
Okay, thank you. There is another question in the chat from Lorenzo about SIR versus SEIR for Marco and Pierfrancesco.
Okay,
let me find that one.
Yeah.
No, the question is why are you using SIR and not SEIR?
We are not actually using SIR, neither SEIR. We're not using compartmental models in this case. Obviously, I think that SEIR actually would be the correct model to use for modeling such an epidemic. Not such an epidemic, I mean, whatever epidemiological event we observe. So yes, SEIR is definitely the right choice, as long as they did allow you to get such a model to convert to reasonable values and in a robust way.
Okay. If people have a question, they can write them in the chat. I have another question because forecasting is very important because you want to explain the future, and everybody wants to know the future. But something which is also very important is looking back to the past to understand, for example, the effectiveness of non-pharmaceutical interventions and things like this. Have you done this kind of work? Cécile?
Yeah, so maybe I'll start. So we started developing models during the first wave, and I mean it was a bit both. So during the first lockdown in France, we didn't really know what would be the impact of such a an intervention because I mean, it was unprecedented in France, and it's also very context specific depending on between countries. And so we tried to estimate the impact of lockdown, but it was not really retrospectively. It was more in real time when we could. So it was more like around 15 days after the implementation of the lockdown, we started to be able to see a signal and see a reduction and try to have an estimate of the level of reduction it had. But we rather did that more in so I don't know if we can call that retrospectively.
Professor Dhersin and others, I would just open and suggest now everybody, due to we are now 25 approximately, I suggest each one just possibly unmutes himself or herself and ask if there is anything additional. I will shortly ask myself also one small question for all, I think a general one. Basically, as the intent was also to present modeling of COVID, do you think that during this pandemic, we have really went further in modeling, naturally with epidemiological models, and in which senses? Where were basically the real, not possibly also in your modeling and so on, where were some real advances? Do you think we got them? There were any? I think this could be really an interesting one. Thanks. We know about compartmental and all the existing epidemiological and so on. Thanks.
Well, I think I think that maybe the most important lesson we learned is the one Kevin, if I am allowed to. Kevin was talking to us before that the importance of collecting high quality data in order to get robust results. I think this is the most important lessons we learned during this pandemic, and this is where we should act first. So make so that in the future, whenever something like that happens, we improve in our collection system, not only for administrative purposes, but for statistical purposes, so that we can address policy toward the right direction. And that's the most important lesson that we learned of. As far as I've seen, from the modeling point of view, the most interesting modeling were addressed at trying to circumvent this issue of, okay, the data are not good, how can we make something good even if the data are not? I mean, as long as we're talking about public data. Obviously, when we're talking about private data or like data for which you have to ask access, some developments has been done there. And obviously, one important thing was the one that Professor Dhersin was talking about before, or to evaluate the impact of the policies that has been undertaken. So does it make sense to consider a curfew, yes or no? This is something that should be investigated, because otherwise it doesn't make sense to make a curfew in the future. Does closing disco and pubs is effective or not? These are the questions that are very important to ask, and some research group managed to ask, and we should bring home as a message.
Yeah, if I may add to that, so I think in terms of modeling advances, maybe kind of the small scale things, also like in Addenbrook's hospital here in Cambridge, there's a lot of modeling going on in terms of using sequencing data in more or less in real time to kind of infer clusters and hotspots within hospital infections on a really small scale. Obviously, I mean, that is relatively new and super interesting, but again, data quality is absolutely everything.
Yes, and if I can add, the data also have to be shared. So open data is needed during the pandemic.
Yeah,
that's clear.
If I may add to that, it's open data, and it requires secure compute, right? With HIPAA and GDPR that you have now, it's really hard. Individual level data, especially as soon as you involve genetics or sequencing data, you just can't really share it openly. So how do you, then you need kind of access to secure compute. So like a cloud service is something where that data relies on it. So it's having good data, and then not circumvening, but complying with the privacy issues that you have around individual level data. That's really what's kind of holds people back a lot.
Yeah, so maybe regarding the modeling and data, so regarding the data, I completely agree. And also on top of, also maybe even if the data are not high quality, just also having a good understanding of just the biases to be able to deal with them. It's just, I mean, already a first step and not always very easy. I know that, for instance, in France, at some point, there's been a change in survey, like a database was updated like in the middle of an epidemic peak, which is was a bit surprising. And regarding the modeling, I think the problem in terms of developing new model is that, I mean, we're kind of working kind of in a rush. And so developing a brand new approaches requires time for validation, etc. So I think there's been a lot of models that have been just reusing old model, adapting them to the current situation, etc. Because yeah.
And it may be dangerous to use brand new models.
Yes, I agree with all of you. And I mean, I think that the advances in modeling have been hindered by this data quality problem. While one thing that has been highlighted during this pandemic is that we need people with competencies, so statisticians, epidemiologists, virologists, but people that have the right background and the skills to properly communicate the data to the general public in an easy way, in a way which is clear, which is not harmful, and which is far from misinterpretation. And I don't know if this was a problem only of Italy, but we had a lot of people joining the wave of the epidemic, and all of them had the necessity to tell their idea, but most of the times their idea was not the reality.
It was also an impression, and I definitely invite everybody to post their own questions also in the public. An impression from some of the conferences was also that some of the modelers are rather afraid. We know some really scandals almost with some models and so on, and it was an impression that some of the modelers, the statisticians and so on, were even afraid of presenting, I don't know, some probability type model or any other type model because they were exposed to the danger of some scandal. What do you think here, or have you also followed the debates? I remember this Danish mask scandal and many others, I think, were there in the several others.
So, I think that
no, please go ahead. Okay,
so
maybe regarding, so I don't know if I would say talk about scandal, but I think there is I know it's always been a concern in the unit to try to just communicating the results properly of the model and just being able to explain to policymakers, for instance, or people who are less aware and that know less the field of like the limits of models and the fact that so for instance we don't talk about predictions, we talk about scenarios to explain that what happens if nothing changes, etc. And in terms of communicating the results, so I think, first I think that there's been a lot of results that have been also shared very quickly I know that I don't think modeling of infectious disease is the field where there used to be a lot of preprint before. And I think now there has been it's been more commonly used. Also regarding like maybe the fact to be scared to share results, I think it's also results that are very sensitive, and so before publishing results that are going to be debated a lot by non-specialists and specialists, it's also always better to be sure of what you put out.
Yes, I think that people have to understand that models are no more than what they are. So models are just scenarios, and they are not predictions. And sometimes when you read the papers or when you see people at the television, they only give the result without explaining that they have some assumptions. And so I think that researchers have to explain the limit of the models.
Yes, definitely. And unfortunately, he has to explain this in a very simple way, because the general public, which usually does not understand much about statistics, etc., must be able to understand the limit of the model, not only the results and the conclusions. And it's a big challenge for us, I think, because I think that the statistical community has never been under such a big I don't know how to say it, a big zoom, okay? So controlled and so observed, okay? So unfortunately, I think it's boring work, but especially when we deal with this kind of stuff, we must be super careful about are we communicating our results and their limitations correctly or not? How can people use my result to say something that I don't want to say? Because there's also that thing that people are able to use whatever you say or whatever you assert to support their hypothesis that has nothing to do with what you're saying actually. So this is the big problem, another big problem we're facing right now.
Completely agree with whatever you said, but I also just want to maybe support the policymaker point of view here a bit, because like from a policymaker perspective, waiting for the perfect answer, sometimes there's just not the time for that, right? So there's a very fine balance between making sure that everything is perfectly correct and getting something, even if it's a only rough approximation of what's going on, anything out in a quicker time. I think speed is also important sometimes. It always goes hand in hand with making very clear the limitations of that model / the additional assumptions and simplifications that you're making. But sometimes having a quick and dirty model out earlier is more important than having kind of the right one 4 weeks later, right?
Yes, I think that we have to explain this to the policy makers, but also to the rest of the population. And this is a big challenge.
So if I may intervene, maybe we can close the discussion now if there are no more questions from the audience. So I want to thank you all for participating in this very interesting discussion. We were able to talk about different aspects of COVID modeling, and I think we learned a lot during these 3 presentations and the discussion. So thank you everyone again, and thank you for attending the webinar. I don't know if you want to say a few closing words, Andrej?
Maybe just a big thank you to all. We are considering next topics. We have seen that there are a lot of topics to discuss. We will see, as I mentioned at the start, Bayesian methods, functional data, high-dimensional data, and so on. The seminars will take place on monthly level, and as noted at the start, are specifically intended for the young researchers like this one today. So I can only invite you to the next webinar in March, and hoping you will follow our work also in future. Thank you to all. I would say that also to the speakers, to the excellent discussant, to the moderators. Thanks a lot.
Thank you very much.
Thank you very much, everybody.
Thanks a lot.
Thanks.
See you soon. Have a nice day. Bye. Bye.
Bye. Thank you.
Bye.
See you all. Goodbye.
Bye.